Preload is an important determinant of stroke volume and therefore of cardiac output. Preload can be defined as the amount of passive tension or passive stretch that's exerted on the relaxed cardiac myocytes by the volume of blood in the ventricle immediately prior to contraction. So as blood flows into the relaxed ventricle during diastole, it stretches out the cardiac myocytes, and that passive stretch is the preload. So preload really is the load of blood inside the ventricle before the ventricle starts to contract, the preload. You can also think of preload as being directly proportional to the left ventricular end diastolic volume and pressure. So as the blood in the ventricle is increased before contraction, the tension and stretch on the cardiac myocytes is increased, and therefore the preload is increased. Within physiological limits, increasing preload by increasing filling of the left ventricle during diastole, for example, leads to an increase in the force and the velocity of the contraction, which causes an increase in stroke volume. This curve shows that the amount of stretch on the sarcomere, or the preload, influences the amount of force that sarcomere can generate upon contraction. So at the cellular level, the degree of actin-myosin overlap is one of the main things that determines the number of potential cross bridges that can be formed, and therefore the maximum force that can be generated upon contraction. This length tension curve plots the sarcomere length, or the stretch from different end diastolic volumes, compared to the amount of tension that sarcomere can develop upon contraction, and therefore the stroke volume that it can achieve. So you can see that this normal resting sarcomere length is not at the optimal length for contraction, but it's actually on the rising phase of the curve. Then, as ventricular filling occurs, the volume of blood in the heart increases, placing more passive stretch or tension on those ventricular myocytes. So that passively increases the length of the cardiac myocytes and therefore their sarcomeres, and that is what allows optimal actin-myosin overlap. Then, upon contraction from this point, more cross bridges have the potential to form, and therefore more tension can be developed with that contraction. So more blood can be pumped per beat, and there's a greater stroke volume, but only to a certain point. At very high preload or high end diastolic volume, the sarcomeres are stretched so much that the actin and myosin filaments barely overlap. And the amount of tension that can be developed with a contraction at this sarcomere length is lower because there's less opportunity for potential cross-bridge formation and force generation, and the result is a decline in the stroke volume. Similarly, at very low preload or low end diastolic volume, the sarcomeres are very short, so the actin and myosin filaments overlap too much and the actin blocks myosin binding. Since very few cross bridges can form, the amount of force generated from a contraction at this end diastolic volume is low and results in a much lower stroke volume. So to summarize, the left ventricular end diastolic volume increases the passive stretch on the cardiac myocytes and their sarcomere, or increases the preload. At the cellular level, this stretch increases the length of the sarcomere, placing it in a position for optimal actin-myosin overlap. Optimal overlap allows the potential for more possible actin-myosin cross bridges to form upon contraction. And we say possible cross bridges because it's the intracellular calcium concentration that then determines what fraction of the possible cross bridges will actually form. We'll come back to this idea when we talk about contractility. More cross bridges means increased tension and increased force of contraction, which means more blood being pumped out of the ventricle and an increase in stroke volume. This relationship between the preload and the contractile force or stroke volume is called the Frankstarling Law of the heart. And it states that the volume of blood ejected by the left ventricle, or the stroke volume, depends on the volume of blood present in the ventricle at the end of diastole, or the left ventricular end diastolic volume. The reason this occurs is because of that length tension relationship in the ventricles. So as venous return increases, left ventricular end diastolic volume increases, and that increased stretch or preload in the ventricle aligns the actin and myosin to produce more force upon contraction, so the stroke volume increases. So at a left ventricular end diastolic volume of around 125 milliliters, the force of contraction developed by the cardiac myocytes causes around 90 milliliters of blood to be pumped out. And if the venous return was increased and the ventricle was filled even more during diastole, that additional blood volume increases the passive stretch on the ventricular myocytes and lengthens the sarcomeres so that the actin and myosin are aligned, forming more cross bridges, producing more tension and a greater force of contraction, which ultimately results in a larger stroke volume. This relationship is important because it ensures that the volume of blood that's returned to the heart will be pumped from the heart. So preload is the amount of passive tension that's placed on the left ventricular myocytes just before contraction. So on the pressure volume loop, preload is found on the lower passive curve at the end of ventricular filling at this point of the left ventricular end diastolic volume and pressure. So at this preload, the ventricle contracts and generates a large amount of pressure, which eventually causes the aortic valve to open, and the remainder of that contraction is used for ejection. Then the ventricle begins to relax and the pressure drops below the pressure in the aorta, causing the aortic valve to close. The ventricle continues to relax with all the valves closed during isovolumetric relaxation until the point where the ventricular pressure drops below the pressure in the atrium. This allows the mitral valve to open and allows ventricular filling to occur. The stroke volume of this normal beat of the heart is the left ventricular end diastolic volume minus the left ventricular end systolic volume, and this is the width of the pressure volume loop. So now let's look at how increasing preload changes the pressure volume loop. So if we allow increased ventricular filling during diastole, then the left ventricular end diastolic volume and pressure will increase, and this point is our new preload. So at this new larger preload, the ventricle contracts and generates a large amount of pressure, which eventually causes the aortic valve to open, and the remainder of the contraction is used for ejection. Since there was more volume in the ventricle just before contraction, the cardiac myocytes and their sarcomeres were more stretched and they can have a more forceful contraction. So that larger force of contraction allows ejection of all of that additional volume. Then the ventricle begins to relax and the pressure drops below the pressure in the aorta, causing the aortic valve to close. The ventricle continues to relax with all the valves closed during isovolumetric relaxation until the point where the ventricular pressure drops below the pressure in the atrium. Then the mitral valve opens, allowing for ventricular filling to occur again. So with this increased preload, there's an increase in the end diastolic volume, but no change in the end systolic volume. So the stroke volume for this beat with the increased preload is the width of this wider red pressure volume loop. So this pressure volume loop shows that an increase in preload, like in the red loop, produces an increase in stroke volume, and this is based on that Frankstarling relationship. There are several factors that determine the preload, but one of the main ones is the central venous pressure or the hydrostatic pressure in the large veins of the systemic circulation. The majority of the blood volume, about 61%, is present in the systemic veins. So there's this great reserve of blood that can potentially be returned to the heart and therefore increase the preload. There's no valve in between the inferior and superior vena cava and the right atrium, so the central venous pressure is equal to the pressure in the right atrium. And the pressure in the right atrium is the driving force for blood to enter the right ventricle during diastole. So any increase in pressure in the right atrium would lead to an increase in the driving force for blood to fill the ventricle during diastole, which would increase the amount of blood to enter the ventricle during diastole or increase the preload. Now, to understand how increasing the return of venous blood to the right atrium can affect the end diastolic volume and pressure in the left ventricle, it's important to remember that the right heart and the left heart are in series. So if there's an increase in the amount of blood being returned to and then pumped out of the right heart, that leads to an increase in the blood volume found in the pulmonic circulation, and therefore an increase in pressure in the pulmonary vein that's returning blood to the left heart. Then, since there's no valve between the pulmonary vein and the left atrium, the pressure in the pulmonary vein is equivalent to the pressure in the left atrium. So any increase in pressure in the pulmonary vein will also lead to an increase in the driving force for blood to fill the left ventricle. That means that any increase in preload of the right heart also leads to an increase in preload of the left heart. So if there's an increase in central venous pressure, that leads to an increase in atrial pressure in both the right and left atrium. And this increases the driving force for blood to flow into the ventricles during diastole. Because of this increased driving force, there's an increased volume of blood in the ventricle at the end of diastole just prior to contraction, which is an increase in preload. There are several factors that can increase or decrease the central venous pressure. The first is the degree of active smooth muscle contraction on the walls of the veins, or the venous tone. So venous tone is regulated largely by autonomic reflexes through neural and hormonal constrictors. So an increase in sympathetic activity can lead to increased tension on the walls of the veins. The increase in venous tone causes an increase in the central venous pressure, and that increased pressure forces some of that large reserve volume of blood in the veins back into the right atrium and increases the preload. The next factor that influences central venous pressure is our total blood volume. Since most of the total blood volume is in the venous system, changes in blood volume can have major effects on the central venous pressure and therefore the preload. So if you were to increase blood volume through fluid intake, for example, most of that volume would be found in the venous system. More blood in the veins results in a higher hydrostatic pressure and therefore an increase in central venous pressure. And an increase in central venous pressure leads to an increase in preload. The next factor is body position and whether you're standing or sitting. So gravity affects venous return and can change the central venous pressure. Upon standing, gravity pulls blood down to the legs and feet and causes a transient decrease in the central venous pressure and a decrease in preload.